Gentlemen, my name is Fanny Lam. I'm going to talk about why is it feasible and why is it important to provide early screening of autism, because autism actually is very heritable and then is highly prevalent. According to CDC, it's actually revised, the prevalence is actually revised to 2.8%, meaning that 1 in 36 children will be affected by autism. And its symptom is actually very variable. The spectrum includes difficulties in reciprocal communication and social interaction, as well as a lot of sensory difficulties. In fact, autism is actually very commonly associated with comorbidities, and the pain point for us right now is that we have too few developmental pediatricians or psychologists in the field to diagnose autism, and that because we rely too much on the behavioral observation, that the diagnosis of autism is highly inconsistent. So we want to look for tools that are scalable as well as more data-driven, meaning that the diagnosis could be more robust and the waiting time for the children will be shorter. So in this review study, we actually perform a retrospective review as well as a prospective review, because we are adding children to our cohort, and then we collect the clinical information as well as the genomic data. So the genetic testing that had been performed ranged from karyotype earlier on to FISH chromosomal microarray, and recently whole exome sequencing as well as whole genome sequencing. By doing genomic testing, we can also offer pharmacogenetics to patients who may need to have tailor-made or precision medicine approach in finding the anti-seizure medication, or as well as some psychiatric medication. So we usually would request for genomic testing for children presenting with autism spectrum disorder features, as well as epilepsy and intellectual disability. So we reviewed about 94 children's clinical notes as well as their genomic data, and we found that the mean age of affected, the mean age of children being affected ranged from 5 months to 17 years and a half, and the male to female ratio is 1.8. Actually, we were able to identify pathogenic cause in 83% of the patient, which is better than the international data, and about 50% of them were identified to have monogenic etiology. And here are the list of the syndromes that we identified in our patients. They include commonly Fragile syndrome, and also we identify some structural defects like focal deletion as well as George syndrome, and we identified some Phelan-McDermid syndrome, and you can see we have Angelman syndrome, Prader-Willi syndrome in the list, and thank the parents for the consent, and also we identify some children with rare syndromes. By doing this, we actually shorten the diagnostic odyssey and allow children to have earlier medical treatment, as well as we expedite the multidisciplinary training sessions. On top of these highly medically actionable syndromes, we also identify some genetic, some genes or gene families. We identify some structural or CNV or SNV in these patients, and these are the common group that like gene family, the channelopathy, the potassium and sodium channel, and these actually will imply the patients may have a lot of comorbidities, including epilepsy and also other structural defect. So this is the limitation of our studies. The earlier patients do not have whole genomics sequencing, and some of the earlier testings may have missed mitochondrial mutations. And not all of our patients have trio studies. And from this background, actually we can move on to discuss how we could diagnose autism earlier in asymptomatic children, because we all know that children undergo a developmental regression at around 18 months of age who are affected by autism. So we want to make the diagnosis as early as possible. And with this background, I think it is very possible, very likely that we could pick up children, especially those with family history, who are at risk of autism as early as infancy and toddlerhood. And actually, this is what I want to add to the phenotype on top of the difficulty with language development. You may have heard this morning that the language development is highly genetic as well. So we actually use the neural encoding, which is we allow a child to listen to a pure tone sound, and then we measure the EEG, and then we can predict up to 90% of the risk of autism. By adding the genomic testing and also the EEG findings, we could predict up to 90% whether a baby or a toddler have a risk of autism when the child grows up. So I think this actually is very important so that we could cut down the waiting time of assessment, as well as we could provide very early on intervention. Because of epigenetics, we understand that we could actually change the trajectory of children's development if they are affected or they are at risk of autism. So here is the QR code if you want to learn more about our program, including the genomic testing as well as the EEG. And we are now adding more scalable tests, including the fecal microbiome as well as the AI facial recognition. So we want to push the diagnosis of autism to as early as possible. So this is my lovely team, and I would like to thank my team as well as everybody's attention this afternoon. Thank you, everybody.
Thank you so much for the presentation. So I think we can allow for a few questions. Anyone has questions to the speakers? Thank you, Dr. Felish. Anyone has any questions to our other speakers? Dr. Fu, Ms. Yun, and also Dr. Muzira?
I think maybe we can start with some questions from here. I think I have a question for Dr. Muzira. What's the progress in the registry or in the establishment of the registry for our public